Wonderful. Well, it's a pleasure to be with you all this afternoon. I appreciate the invitation to share a little bit. I was asked to give a talk on the psychological impact of chronic illness. I'm sure a lot of you in the room can provide your own input, maybe when I'm finished, about personal experience. But the first thing I really wanted to do was to normalize the fact that chronic illness and living with chronic illness takes an emotional toll. And there's been a lot of research on, the fact that chronic illness, it causes depression 2 to 3 times more so than the general population. There's a number of studies. The CDC has found that up to 19% of people living with arthritis have frequent mental distress, 32% of a history of depression. People with migraines, twice as likely to have mental health distress than those without. Rheumatological conditions, rheumatoid and psoriatic arthritis, there's been studies about the mental health impact of living with those conditions. And then perhaps most relevant, but there was a study that's shown up to 50% of adult women, specifically with Chiari, meet clinical criteria for PTSD. So clearly there is an emotional toll just living with chronic illness. It tends to cause some depressed mood. In addition to all the normal risk factors for depression that we all have as normal healthy people with personal history or family history, environmental stressors, all those things that can increase your risk for developing depression. Living with illness has other, on top of those normal risk factors, other risk factors directly related to having the illness. Just receiving a medical diagnosis can cause sadness. It's a change to your worldview and your style of life. There is a lot of related functional limitations that come along with living with chronic sickness. So things tend to slow down. You don't have the same level of stamina. Work capacity is often reduced, which can cause this whole cascade of loss, losing jobs, losing houses, even losing marriages and relationships. Favorite activities, self-care, traveling, everyday tasks, just cooking, cleaning, all those things become harder when you're sick. And illness costs money. It costs time to treat. Your opportunities dwindle. Your stamina is limited, so you have to prioritize things. You have to, unfortunately, focus on things that are needed rather than wanted in life, and all of that can influence and exacerbate depressed feelings. In addition, some of the medications we use to treat chronic illness can have side effects that can look like or cause emotional distress. Pain is very debilitating and is a known risk factor for depression. There can be debilitation from other types of treatments for your chronic illness, and just the stress from managing day-to-day can cause depression. And then finally, specifically with neurologic conditions, some of those direct changes in the brain can cause a direct impact on mood. The impression of brain tissue, disrupted flow of cerebrospinal fluid, damage to nerves, all of that can actually directly impact mood. And in turn, depression tends to have this influence on physical well-being as well. It can beget illness. There's studies that show that people of all ages with depression are at higher risk of developing certain physical conditions like cardiovascular disease, diabetes, stroke, even Alzheimer's disease. And there's speculation about why that is, but probably is related to some combination of variables. But people with depression tend to have some greater difficulty caring for themselves and taking care of their physical needs. There may be reluctance to seek medical care when it's needed. Unfortunately, people with depression sometimes have trouble complying with medical recommendations. It's hard to do these things, especially when you have the anergia, which comes with depression. Following treatment protocols can be more difficult. Maintaining a healthy diet and routine physical exercise, those core functions of being physically healthy, can get hard when you're depressed. Depression can also cause physiological changes that can play a role in developing illness. It's been associated with increased inflammation, changes in heart rate, blood circulation, abnormalities in stress hormones, and metabolic changes. And there's this tendency that when you have depression and another medical illness, both of those things, when you have both together, tend to be more severe. The symptomatology looks a little more significant when you're dealing with both. And while sadness is a normal response to a new diagnosis, any change in life can cause sadness. We call that an adjustment response, which is quite normal. But if symptoms persist longer than what we kind of feel like is an appropriate period of adjustment, maybe a couple weeks or months, it might suggest an evolution from a normal adjustment response to a more clinical depression. And I just listed some of the symptoms of depression so that you can maybe self-monitor a little bit. But persistent sadness, feeling hopeless, pessimistic, irritability can be a manifestation of depression. People don't always feel sad, but could feel irritable, feeling guilty or worthless, loss of pleasure, loss of interest in normal activities, loss of interest in socializing, decreased energy, fatigue, sounds a lot like physical sickness too, difficulty concentrating, difficulty sleeping, changes in appetite, and even some suicidality. But the reassuring thing is that depression is treatable. And I think a collaborative care approach where you're approaching both the mental and physical healthcare needs is optimal. Research has shown that treating depression and chronic illness together generally helps people better manage both. However, there is unfortunately some reluctance still on the part of patients to seek psychological care if it's needed. There's still unfortunately a little bit of a social stigma about it, despite how very normal it is. There is cost associated with seeing a therapist week in, week out. And particularly now, and there's a limited availability of providers. This has been an unfortunate part of, I think, the pandemic drove up the need of mental health nationally, internationally, and there's just kind of a dearth of providers available to help manage those needs. So that can get in the way of care seeking. Patients, with physical illness have limited time and mobility sometimes to get to appointments. I say one silver lining of the pandemic is that it's opened the door to telemedicine. And I think the accessibility of mental health care has grown as a result of that. So if there's one silver lining from COVID, that's certainly something to consider. And I would say a first step if you're struggling emotionally is to talk to your primary care provider. And some tips if you are ready to do that, if you're feeling a little distressed, don't wait for your provider to ask how you're feeling, but bring up any difficulties you're having with them so that they can help, identify the need and refer you to appropriate professionals. I would prepare ahead of your visit, make a list of concerns, prioritize those concerns, bring a list of medications. If there's a question about medication, you don't want to have contraindicated drugs on board. Review your family history. If there's a mental health history of the family, that might be a risk factor for you as an individual, and it might trigger a different kind of avenue or approach to treatment. Be honest, open. Describe your symptoms, their severity, their frequency, any environmental stressors that could be triggering or making worse your symptomatology, and then ask about next steps. We all know that different avenues for treatment for depression include medications and psychotherapy. And the best outcomes typically come when both are used in conjunction. So, your primary care physician might be able to prescribe a medication for depression if they're comfortable with that. Maybe your neurologist or neurosurgeon could prescribe something like that. And if not, maybe they would trigger a referral for psychiatry. So psychiatrists are medical doctors that manage the medical side, the medical treatment for mood disorders and other psychiatric disorders. So they prescribe medications. And then psychologists, social workers, clinical or licensed therapists do the talk therapy. So seeing a provider in each kind of area is generally most helpful in treating the underlying condition. And treating depression improves mood, obviously. It also then improves physical symptoms. So there's a lot of research that suggests that mood distress, emotional distress, can cause, independent of chronic illness, its own kind of host of physical symptomatology. And so managing mood really, it helps with sleep, it helps pain, it helps with emotional distress. Just like treating your chronic illness, getting those symptoms under control can improve the symptoms of depression. So there's a lot of overlay back and forth between these two things. They're very interconnected. But it's important to remember that there's no one-size-fits-all approach to treatment. A lot of times, especially with medications, it's a trial and error, see what works and what doesn't, what a patient responds to. In one patient responds well to this drug and the next one doesn't. It's very individual, it's very trial and error. It might come to be that a combination of treatments and approaches is the best for treating an individual. And regarding therapy, I really would encourage people to shop around. It's okay to have an initial visit with a therapist and feel like you don't connect or you don't want to go back. That's fine. The thing about therapy is that it works best when there's a good relationship. So if you feel like you meet with somebody and you're just not connecting, it's okay, and you really should move on. You really want to try to find someone you're comfortable with, because that's when therapy really works. And I would say also, I have a lot of patients ask me about, should I have a PhD level psychologist, or would seeing a social worker or other different types of providers be fine? And I would say any would be fine so long as the relationship and the connectivity is there. It's for me, more important than a degree is the level of, is the quality of the relationship, because that really is what leads to improvement and leads to progress in therapy. And I just wanted to throw up a few slides if you're in a position where you're looking for resources, and if your primary care physician or other doctor isn't sure where to send you. There's lots of federal resources, federal agencies that offer help in finding healthcare providers, especially, if there's financial concerns, finding low-cost health services, finding providers in your specific geographic region. So I don't know that I need to read through all of these, but the Substance Abuse and Mental Health Services Administration, they have online treatment locator, the Health Resources and Services Administration. They've really been working to improve access to healthcare and affordable healthcare. They offer care, or they help locate care on these sliding fee scales. So these sliding fees tend to be, there's depending on need and your financial situation, they might offer a different fee for service than they might somebody in a different position. Centers for Medicare and Medicaid Services has information on their website about benefits and eligibility for mental health programs and how to enroll. The National Library of Medicine on Medline Plus has directories and lists of organizations that can help you find a healthcare practitioner. There's national agencies and advocacy and professional organizations. Some also have practitioner locators on their websites. So a couple examples there. state, county agencies, insurance companies, believe it or not. I often, when I'm suggesting that a patient see a therapist, I will often say, contact your insurance company because they'd be able to provide a list of other providers, so who they cover in your geographic region. And that oftentimes is a great start point in finding somebody who your insurance will cover. And then universities, colleges, a lot of training programs, they offer a sliding scale of reduced cost services with trainees, always under the supervision of a seasoned therapist who of course would help directing them and managing their care. So trying to find, through psychiatry, psychology, counseling, social work departments at medical schools or universities is often a good avenue for finding help. And then finally, just a few suggestions. If you're feeling distressed but not quite ready to jump right into, a formal therapy kind of situation, there's some things that, have been shown to also be beneficial in terms of managing the psychological impact of chronic illness, life. But joining a support group, according to the Mayo Clinic, a support group among people with shared experiences can function as a bridge between medical and emotional needs. You can find support groups online in social media platforms. In-person groups are really great, I think, even better than kind of online platforms, but searching in a local hospital or community center could help with connecting you to a local support group. And sometimes the support groups are, disease or pathology specific, sometimes they're situation specific, but there are a lot of resources out there. Given the connection between depression and inflammation, sometimes changing your diet can be really helpful in managing emotional distress. There was one study recently that showed symptoms of depression dropped significantly after subjects cut down on processed foods, sugars, carbs, and tried a more kind of produce-heavy Mediterranean diet that's kind of the fad right now in terms of managing inflammation, which can have a lot of physical health benefits, that kind of approach to food. Another suggestion I saw was finding a pocket of goodness in your day, feeding your soul. So try to find parts of your life where you feel contentment and build on that. If there's something you love doing, try to do more of that. Again, that when you have limited energy and resources, you have to prioritize needs over wants sometimes, but try to find at least part of the day where you're doing something you love. Caring for animals, if you can physically manage it, there's been a lot of research on the emotional benefits on having a pet and improving your mental outlook. In a survey of 2,000 pet owners, 75% reported improvement of mental health after getting a pet. There's physiological changes that come from positive human-animal interactions, including reduction in psychological stress and an increase in oxytocin levels in the brain. There's also a growing area of research called ecotherapy that's really found a strong connection between time spent in nature and reduced stress, anxiety, depression. There seems to be a reduction in the part of the brain or less activity in the brain where the ruminations happen just after walking in a natural setting. It helps to lower blood pressure and stress hormones as well. And then finally, get creative. So the World Health Organization has reviewed over 900 publications on the arts and health, which concluded that engaging with the arts can be beneficial for both mental and physical health. Spiritual practice, and that doesn't necessarily mean religion, but meditation, mindfulness, deep breathing, guided imagery, all those techniques have proved to be helpful coping strategies for many. When I work with patients with cognitive impairment too, so mindfulness is one of those strategies that I recommend for patients with some attentional problems too, just training to be present in the moment, which is helpful in terms of not, with depression, with anxiety, we're always stressed about what's happening next, but being in the moment, so to help with attention and with emotional control, it's really effective. And I included Headspace as an app that's widely available. It's kind of like training, and there's also a great podcast out of UCLA on mindfulness, so just a couple other resources there for you. And then finally, rethink napping. So napping is not a punishment for being tired, but it's really a way to re-energize. And, just a few strategies for everyone. I'd be happy to take questions if anyone has questions.
Yes, we're gonna open it up to questions for Dr. Lester at this time. So if you have a question, just raise your hand. We'll get a microphone over to you and let Dr. Lester take a couple questions. Anybody? Any question? So there's one right there.
It's been my experience. It's been my experience that insurance companies make it very challenging to reach neuropsychologists. So any recommendations for somebody seeking that level of help with navigating our insurance landscape right now?
So I think insurance companies make everything really difficult, and it's really unfortunate that thing is getting in the way of healthcare, and I think it really is a roadblock that shouldn't be a roadblock. A neuropsychologist is I don't know if you mean specifically, so a neuropsychologist, I'm a neuropsychologist, and most of my day-to-day job is doing diagnostic evaluations when there's some cognitive impairment. Is that what you're really after?
Yeah, this was kind of more along the lines of like book rehab and just somebody who, if you were talking in the beginning about like assessing like when somebody's more than stuck. So I guess I think.
So for intervention.
Yes.
Yeah. I think that insurance is very prohibitive. I think there is a huge need for mental health services, and in the structure of things right now, we're just not meeting that need, whether it be the lack of providers or insurance and costs getting in the way. I'm not sure I have a great answer in terms of connecting, but I would say my best strategy in terms of finding a provider that your insurance covers is to ask your insurance company for providers they cover. Does that help at all?
That didn't work, but thank you.
I'm sorry. I don't have, I know I'm in Philadelphia, so and my list of providers would be useless, but, try to network with other people either that have been dealing with similar situations or with your team of medical providers to see if they have any recommendations.
Any other questions? So, Bill.
You mentioned a connection with Chiari and PTSD. I know in the past 2 years I've been diagnosed twice with PTSD and then the Chiari. So I'm always trying to figure out, is this PTSD or is this Chiari? So if we can talk about that at all, I'd be appreciated.
I honestly, so I don't know. My interpretation of that was almost like a traumatic response to being physically unwell, to receiving a diagnosis that could potentially, involve a lot of difficult treatment and be, persistent and not go away. I don't know that I would understand to relate, I mean, in terms of, so your diagnosis of PTSD came before the diagnosis of Chiari?
Yeah.
Yeah, so I don't know that I didn't interpret it that way, that PTSD could, potentially, or that the Chiari, like the neuromechanical, neurobiological effect of Chiari, if it was present before it was diagnosed, but that itself might cause PTSD. Anyone else in the room able to give insight about that?
Not without an exhaustive history of medical, past, social, everything. That would take a long time.
As a physician, I wouldn't touch that without a full, exhaustive medical history. Everything, including the past history. There's a lot to dive into that. So that would take a long time, long consult.
I missed the first comment.
Just saying, trying to diagnose PTSD, trying to relate that to the Chiari. If that was diagnosed before the Chiari diagnosis, like you said, from a neurochemical, neurobiochemical, however you want to say it,
Right.
ascribing the PTSD to the Chiari would be, to me, inappropriate to yield onto that road without gathering a complete and exhaustive medical history about everything. Social history, past history, emotional health, emotional, psychological well-being, physical ailments, everything else that can contribute to it without trying to ascribe that together.
Right. And really, I mean, the core diagnostic criteria for PTSD is trauma. So having experienced trauma is an essential component of making that type of diagnosis.
I have a question. Okay, so I want to know how your role works in the office with patients. I think it's just fabulous that you're there. And I want to know how you interact in the office. I mean, are you just seeing patients, or are you part of the surgical team for the more prevalent surgeries? I mean,
So my role really, and I want to again, so I'm a little bit different in terms of being a psychologist. I don't do a lot of the therapy and intervention that I just suggested. I make a lot of referrals for that kind of intervention. But what I do as a neuropsychologist, I see patients for these very lengthy assessments of cognition and psychological status. So we do, objective testing on how well a patient's memory is working and attentional skills and all these different domains of thinking, and try to identify if there is, in fact, some area of impairment and what might be underlying that and what might be the best avenues for managing that. And sometimes it's neurologic disease itself. Sometimes it's the emotional response or other, psychiatric distress. And a lot of times it's both. And so my job, I work in an office predominantly. I have patients that are scheduled for, 4 or 5 hour blocks of time that I spend face-to-face getting history and doing this lengthy neurocognitive testing, and then might make some recommendations for things like therapy and medications if there is a clear psychological component.
okay.
Allison, I can speak to that too. I mean, Dr. Weston is doing a lot. I mean, she is a beyond integral part of our team, and just being able, it's been kind of loud cough, I cannot. Just being able to see a patient in the office and try to differentiate people having memory issues, some of the Chiari patients that are having really predominantly severe memory issues. I think at most places, it's get a neuropsychological evaluation. That's not easy to do. I mean, as I think several people have said. So all of our physicians, we communicate very frequently with Dr. Lester and her team and say, hey, he's Mrs. Smith, this is what I'm concerned about. We'll email back more. So that communication, that ability to be able to have, what in this day and age, you have 5 hours to sit and take that day with one patient. So it's a huge piece. And I think the discussion that was brought up earlier, something has to be done about the insurance companies because the right thing is anathema to their bottom line in multiple things. And that's where it's becoming a bigger and bigger problem. And let me tell you who the customer is, everybody in this room. And people forget, we as doctors are also patients, and we have families who are patients. So we as patients have to put our foot down the insurance companies because that's the only people that are making money right now. And in the pandemic, just not to go off on a thing, they made record amount of profits because think about it. Did anybody in this room get their money back for their deductions when they weren't even allowed to go to the hospital? Right? They were still charging you. You were still paying your premiums, but they weren't paying anything out because nobody was going to the hospital. So, I mean, there has to be something that gets paid forward.
Yeah. Wonderful. Any additional questions? Okay. Well, Dr. Lester, thank you very much for your contribution. We
Thank
truly
you.
appreciate it.
Thanks for having me. Enjoy the rest of the conference.